Now, breast cancer, basically clear as mud, and I think we'd all agree. Fortunately for this little guy, he's adorable and he made it through. But I think most of us would agree that when we start talking about breast cancer, you can almost find a paper or a study that answers whatever question you want to answer. And so I wanted to kind of go over some topics, especially some recommendations that have come out over the last year that are being more widely accepted. And so we'll talk through those, and hopefully you can incorporate some of these into your practice. So we've come a long way, absolutely. This kind of surgery is not being done anymore, thank goodness. We know that lumpectomies are standard of care. It's been that way for over 20 years. But even with lumpectomies, we don't have a good consensus on what the margins should be for a lumpectomy. We've made advancements in imaging and adjuvant therapy, in ipsilateral tumor recurrence rates, but what the actual margin is for a lumpectomy, no one really knows. And there have been several surveys that have gone out for different specialists, radiologists, pathologists, surgeons, oncologists, on what they think the accepted rate or the accepted margin should be for a lumpectomy. It varies from anywhere from no ink on tumor, 1 millimeter, 2, 5, up to a centimeter, which is pretty crazy. So why all the fuss? Well, we know that the re-excision rate is about 20 to 25%. And Dr. Moran, who is a physician and an investigator out of Yale, she looked at this rate and said, you know what, this isn't acceptable, and I don't think it's really should be this way in the future. And so that's what led the first topic that I'm going to talk about, which is her work on the new recommendations for margins for lumpectomy. The definition of adequate margin has always been controversial, as I just said. And what do we know? We know that if you have a tumor that undergoes breast conservation therapy with a negative margin, followed by whole breast radiation, that it has the long-term survival equivalent to that of a mastectomy. We've known that for a long time, which is great news, but what that margin should be on the lumpectomy is still very much unknown. Minimizing unnecessary surgery while still maintaining excellent outcomes. That's everyone's goal, obviously. Since this data has been published, a lot of large institutions have started going back and looking at their own data and looking at the reasons why they did re-excisions for positive margins or close margins. And most of them are finding that up to 50% of the time, that margin didn't actually have to be re-excised again. So I think with the data that we're going to talk about next, we're going to see that a lot less surgery needs to be done. Facilitate timely post-op radiation and chemotherapy. As we all know, when we're talking to our oncology buddies, got to go back to the OR and re-excise a margin. It's going to take another week for that. Pathology comes back, then you have healing time, and all of a sudden you've waited several weeks until you've actually started your post-operative therapy. Decrease patient psychosocial stress, physical discomfort, and cost, which I think goes without saying. So, the new guidelines, which were developed by the Society of Surgical Oncology in conjunction with the American Society of Radiation Oncology, they were endorsed by the American Society of Clinical Oncology and the American Society of Breast Surgeons. So it's a lot of words to say that a lot of people are on board with these new lumpectomy margin recommendations. And you can find this paper, which is published in March 2014 in many journals, and you don't have to have subscriptions to these. It's easy to find online. So, the SSO and ASTRO put together a multidisciplinary panel. And on this panel, there were about 12 providers. And these providers are experts in their field: breast surgery, radiation oncology, medical oncology, pathology, and even patient advocates from the Susan G. Komen Foundation. So they all got together, and over 2013, they asked this clinical question: what margin width minimizes the risk of ipsilateral breast tumor recurrence? And what they did was a meta-analysis of margin width and ipsilateral breast tumor recurrence from a systematic review of 33 studies, including over 28,000 patients, where over 1,500 have ipsilateral breast tumor recurrence. Now, certainly within that, they looked at what were certain clinical characteristics that would play a part in this: patient age, tumor histology, were they getting adjuvant therapy, what kind of radiation therapy were they given? And here's their final recommendation. The recommendation is No ink on tumor is the current recommended guideline for patients with invasive breast cancer, stage 1 or stage 2, undergoing breast conservation therapy and postoperative whole breast radiation. And as you can imagine, this is going to really change what patients go back to surgery, especially when we're talking about the fact that some physicians are saying 0.5 to a centimeter margin is what is actually acceptable. Now, I do want to say that in this study, DCIS, patients only with DCIS were not included, and patients who underwent neoadjuvant chemotherapy, they were also not included. So they gave a set of about 8 practice guidelines, and I want to just talk through those. So we know the blanket statement here, no ink on tumor for early breast cancer, but let's talk through these 8 practice guidelines so you know exactly what they're recommending. Positive margins, as defined as ink on tumor, or DCIS, are associated with at least a 2-fold increase in ipsilateral breast tumor recurrence. I don't think anybody would have an argument for that. And this increased risk is not nullified by delivery of a boost, delivery of systemic therapy, or favorable biology. Systemic therapy meaning endocrine therapy, biologic therapy, chemotherapy. Favorable biology meaning ER-positive tumors. So here you can see a picture, and this was provided by our pathologist regional laboratory. We have a positive tumor here, positive ink on tumor. This patient has to go back, and I don't think anyone would argue that. So, guideline number 2, negative margins, or no ink on tumor, optimize ipsilateral tumor recurrence. Wider margins do not significantly lower this risk. So they said, okay, let's look at what people are defining as their own margins of acceptability. So they looked at no ink on tumor, 1, 2, and 5 millimeter margins, and compared that to the ipsilateral breast tumor recurrence rates. And what they found was there was no statistical correlation, so that as margin width increased, the ipsilateral tumor recurrence rate did not decrease. And here, this is just giving you a visual of this is a 2 millimeter positive margin versus a 1 centimeter. So the mental margin out there that people are accepting as sort of their own bias is pretty varied. The rates of ipsilateral breast tumor recurrence are reduced with the use of systemic therapy. And we know this. We know that patients who are ER positive, undergoing breast conservation therapy, who are given tamoxifen after surgery versus not, have a decreased ipsilateral breast tumor recurrence rate. But in the event that a patient does not receive adjuvant systemic therapy, there's no evidence suggesting that margins wider than no ink on tumor are needed. In addition, margins wider than no ink on tumor are not needed based on biologic subtype. So for example, the panel says, let's say we look at HER2 positive patients. We have a subset that are getting breast conservation therapy and radiation. We have a second subset who's getting a mastectomy. Their ipsilateral breast tumor recurrence rates are very similar, indicating that margin is not the culprit here, it's aggressive biology. The choice of whole breast radiation delivery technique, fractionation, and boost dose should not be dependent on margin width. And they do say during that you need to, as a radiation oncologist, you do need to look at the whole person and all of the tumor biology and look at what are their risk factors for failure, but not basing radiology delivery method solely on margin width at the lumpectomy site. So, margins wider than no ink on tumor are not indicated for invasive lobular cancer. Classic LCIS at the margin is not an indication for re-excision, and the significance of pleomorphic LCIS at the margin is uncertain. So, we know that invasive lobular cancer comprises about 5 to 15% of all breast cancers. When you look at the ipsilateral tumor recurrence rate, when you compare invasive lobular versus invasive ductal, they're very similar. We know that classic LCIS is a risk factor for breast cancer, so we're not trying to obtain positive or negative margins for that. And then finally, this pleomorphic LCIS, which can be a bit of confusion. So when we say pleomorphic LCIS, we mean it could harbor pathology that resembles high-grade DCIS. The studies regarding pleomorphic LCIS are very small retrospective studies, and so we don't have great recommendations on what the margin status should be for that. Now, at the end of their paper, they say, you know what, if it's safe for the patient and they have a positive pleomorphic LCIS, maybe they should undergo a re-excision. And here's the last one, which I think for all of us mentally is the hardest one to grasp. So patients of a young age, less than 40, we know that they're associated with both an increased risk for ipsilateral breast tumor recurrence after breast conservation therapy and an increased risk for local relapse on the chest wall after mastectomy. And they're more frequently associated with adverse biologic and pathologic features. There is no evidence that increased margin width nullifies the increased risk for ipsilateral breast tumor recurrence in young patients. And I think for most of us, me included, when you do a lumpectomy for someone in their 30s, it helps you sleep at night when they have a 1 centimeter margin. It just does. But there's no evidence to say that over time that will increase or decrease their ipsilateral breast tumor recurrence. So we need to kind of pull in the reins on doing unnecessary surgery based on emotion opposed to actual evidence-based medicine. In their last guidelines of the 8, an extensive introductal component identifies patients who may have large residual DCIS burden after lumpectomy. There is no evidence that an association between the increased risk for ipsilateral breast tumor recurrence and EIC when margins are negative. So, what we found in the past is when you have this extensive introductal component, when patients have gone back to surgery in the past for either a positive margin or for a close margin, oftentimes those re-excisions come back with DCIS, which is fairly rare. Usually when you take someone back, that re-excision comes back negative. It's led people to believe that an extensive introductal component may indicate that that patient has multifocal DCIS disease in the breast. But what they're saying is, after looking over this evidence, there's no increased risk for ipsilateral breast tumor recurrence even with this extensive introductal component. Now again, you have to look at the patient as a whole. So if they have suspicious calcifications in the remainder of their breast, etc., then they need close mammographic follow-up. So, to summarize, so if you're going to leave this talk today, here are the things that I want you to keep in your mind, okay? Incorporate into your practice. No ink on tumor is an acceptable guideline in patients with stage 1 or 2 invasive breast cancer undergoing breast conservation therapy with post-whole breast radiation. Exceptions to this were solely DCIS in patients undergoing neoadjuvant chemotherapy. Among experts, the consensus is mastectomy plus or minus DCS requires at least no ink on tumor. DCIS alone, still the accepted margin is a minimum of 2 millimeters. And negative margins are not necessary for classic LCIS, which we know is a risk factor, atypical lobular hyperplasia, or atypical ductal hyperplasia. And it still does leave that category of pleomorphic LCIS, and potentially in certain patients, we should go back and be taking margins for those. So, you might be sitting there and saying, well, thanks, Sal. You're a surgeon. Sounds like that affects your life. Doesn't really affect my life, right? And when I went through and decided what I wanted to talk on today, I looked at who actually registered for the conference. And there's a lot of students here. We have a lot of primary care and nursing people. And you guys are more at the forefront of breast cancer. I'm at the tail end. Fortunately, you guys make the diagnosis for me, and then I get to go in and do my favorite thing, which is operate. But what can be done for the forefront, for the headliners who are actually screening these patients, okay? And I think that, and I'm just going to talk briefly on this, so hopefully you can take some tidbits home and just some practical things home to your practice. I think that a lot of women fall through the cracks as far as risk reduction goes. So let's just talk about what the national guidelines are for actual breast awareness. So the NCCN guidelines for breast awareness, when we think of it, we think of October is Breast Awareness Month. We're going to promote mammograms. Problem solved. Well, the NCCN guidelines say that the actual modalities of screening incorporate 3 things. We're talking about breast awareness, physical exam, and then risk assessment. And the risk assessment is what I really want you to take home today. So as far as breast awareness goes, we're educating patients on how to do their self-breast exams, when to do them. Every single woman that comes through my office, we have at least a few second conversation about this, even if we're getting a gallbladder done. When to do them once a month after the week of menstruation. And then I teach every patient how to do a self-breast exam. And I know we all know how to do this, but as long as you're giving people, empowering them to be able to examine themselves in an appropriate way and signs and symptoms to look for, that's breast awareness. So then that goes on to the actual physical exam as part of the modality of screening. And this is where us as clinicians and nurse practitioners and nurses come into play. So we're doing a clinical breast exam. We're checking the lymph node basins. I've never had one patient, I teach every patient how to check for lymph nodes. I never had one patient say, yeah, knew that before I came here. Every single one of them is like, I had no idea that's where my lymph nodes were. So education is a big deal. And of course, we're looking at the whole body. Clinical breast exams should be done by a medical professional, obviously. They should be started for women between 20 and 39 years of age, have a clinical breast exam every 1 to 3 years with the promotion of breast awareness. For women greater than 40 years and older, they get an annual clinical breast exam. They're encouraged about self-awareness, and they start their screening mammograms. And if any woman ever tells you that, oh, I can just skip 2 years because my insurance changed or because, you know, it was my kid's birthday or something, absolutely not. Everybody gets one every year. So this brings us into risk assessment, which is what I really want you guys to take home because you all are actually calculating this more than I am. So a patient comes into your office, they're for their well woman exam or whatever you're seeing them for. There's a list of questions that you should be asking every woman. And this is a list of questions that I have in my office that every breast patient gets asked. And you think, what's with this specific list? Well, these are the questions that are asked on the Gale Risk Assessment tool. So, the third component of screening modality according to national guidelines. And the Gale Risk Assessment tool, which I'm sure we all know, but calculates the estimated risk for developing breast cancer over the next 5 years and over their lifetime, compared to a woman of the same age, race, and ethnicity from the United States. So you say, that's great, Sally, but what am I going to do with this information and with this data? Well, it affects what your recommendations should be for this patient. For someone with a 5-year risk greater or equal to 1.7, they should be offered risk reduction therapy. And these are women who aren't coming to me. These are women who are coming to you. A lifetime risk greater than or equal to 20%. Now, this isn't going to be based on a Gale model. This is going to be based on a model that is strong with family history. Should be offered annual MRI in conjunction with their mammogram for a screening modality as well as risk reduction therapy. So at this point, we're identifying women just in our screening, just in that well woman exam, who may benefit from tamoxifen or some sort of risk reduction therapy or potentially annual MRI as part of their screening modality. I was just introduced, I was at the American College of Surgeons a few weeks ago, and they introduced us to this app, and I wanted to explain this to you because it was new to me, and it's actually pretty amazing, and maybe you can take this home and incorporate this into your practice. So it's called the Hughes Risk app. This is the website where you find it, and it's very easy to use. And basically, you log on. This is exactly what the web page looks like. You log on, you click Begin New Patient. The next screen will ask you all of the cancer history, not just breast cancer, but any other type of cancers that have been in that patient's family, age, etc. You type this data in. The next screen asks you a series of questions. And these series of questions you've already asked the patient because you have a standard list in your history and physical that you have ask every woman. And this is basically the information to answer the Gale Risk Assessment. And so what it generates for you, instead of having to go to a million different websites, is one site where it calculates multiple different percentages based on different types of risk reduction calculators. So we have BRCA Pro, TC, Myriad, Gale, and you can choose from that what is appropriate for your practice. This is the easiest thing that I've ever come across, and hopefully will simplify your practice as well. Not only is it just doing risk for breast cancer, but risk of BRCA1 and BRCA2, as well as ovarian cancer. And then the final printout, if your patients are interested in this, will give you the actual pedigree and then their overall data. So something that I found recently online that I was hoping would be beneficial to you in your primary practice, on the ASCO website, there's a family history questionnaire. And basically, we all send out a pile of information to our patients before they actually come and see us. But none of that, every patient that comes to me, nobody knows their family history. And we've all been there, you know? And you're thinking, how can I calculate all of these things if I have no idea of what this patient's family history is like? This is a 3-page printout that you could print out from the website, which is free, and send it with their information, and it tells you, it kind of forces the patient to go back through their family history, find types of primary cancers, ages at diagnosis, lineage, ethnicity, any genetic testing, so that that could be filled out before it actually gets to you. So, if you are on the forefronts of risk assessment, the biggest thing you're asking, most of the patients that are coming in probably don't have symptoms regarding their breast. They're asymptomatic women who are coming in for their well woman exam. So the biggest question that you have to ask is this woman at a normal risk, or is she at an increased risk for breast cancer? The NCCN guidelines define increased risk as prior history of breast cancer, women 35 or older with a 5-year risk greater than 1.7 on the Gale model, women with a lifetime risk greater than 20%, and now we know how to calculate those, previous therapeutic radiation, women with LCIS, and a pedigree suggestive of some sort of genetic predisposition or known BRCA positivity. And for the interest of time, we won't go through the algorithms of these, but the NCCN guidelines talk you through the exact algorithm of what that patient should have, what kind of workup, what kind of imaging, and what sort of risk reduction should be offered for them. So we've said risk reduction a lot, but what exactly does that mean? The NCCN guidelines divide this into 3 major categories. The first is my favorite. It's lifestyle modifications, because it gives the patient power, and it gives them some ownership over the situation, which most people with cancer feel very helpless to. So what we know is weight gain, embrace yourself here, okay? Weight gain and obesity in adulthood are risk factors for postmenopausal breast cancer. So we know that if you gain up to around 20 pounds past the age of 18, and I know everyone's sort of squirming in their seat right now, okay? If you gain 20 pounds past the age of 18, it can increase your risk of breast cancer by 15%, of postmenopausal breast cancer. 55 pounds after the age of 18 can increase your risk by 45%. Postmenopausal women who have a sudden onset of weight gain, 20 pounds, can increase your risk of about 18%. So that is a risk factor that we can put back into the patient's lap to give them some control. The other is alcohol consumption. The NCCN guidelines recommend 1 to 2 drinks, other guidelines recommend 2 to 3, but we know that alcohol consumption of anywhere between 1 to 3 drinks per day can increase your risk of breast cancer by about 20%. And then finally, exercise. And we all kind of wish that perhaps exercise increased your risk of breast cancer, but it does not, as we know. So we know that exercise decreases your risk of many cancers, including breast cancer. And the ACS recommends about 2.5 hours of aerobic exercise a week. We know that walking 30 minutes a day can decrease your risk of breast cancer by 3%. So let your patients know them and put the power back in their lap so that they can take some control too. Obviously, we all know of our risk reduction agents. These are patients where when you are doing your risk assessment, greater than 1.7, greater than 20%, should be starting to have discussions on whether these agents would be therapeutic for them. And then finally, risk reduction surgery. The only time that this is really done and legitimate is for BRCA positive patients, where we do bilateral total mastectomies, and certain cases of LCIS. Now, patients are requesting, as we know, prophylactic mastectomies all the time now. But as far as guideline goes, these are the situations where those are actually warranted. If a patient is BRCA positive, they should also be offered bilateral salpingo oophorectomy due to the increase of ovarian cancer. So I'm going to tell you just 4 things that we're doing at St. Joe's, not to toot our horn, but to say, hey, I'm from a different institution. We want to up our game as far as breast cancer goes. All 4 of these things have been implemented over the last year and are things that you can do at your institution as well. We've started a breast cancer tumor board, so complicated cases are talked about by a panel of physicians. Breast cancer isn't necessarily easy. We've had a beautiful talk just now about the biology, and the more we learn about this, the more complicated treatment's going to become. And so us sitting down together around a table, I think, has forced us at our institution to think outside the box and come up with some good solutions for complicated situations. A multidisciplinary approach. It's very interesting to me. If you take a woman with colon cancer and a woman with breast cancer, the additional needs that a breast cancer patient needs is very different from any other types of cancer that I've seen. Every patient that comes to me who has a diagnosis of breast cancer gets a nutritional consult, they get physical therapy, they have emotional support and counseling that's available to them. They have a breast cancer support group and a breast cancer exercise group. They may not want all these things, but they should be offered. And finally, over the last year, we're getting 3D mammo and have become, due to Dr. Grauke's efforts, a breast imaging center of excellence. And I tell you that because if you are wanting to make advances at your institution, just do it. Just do it. You're going to be happy that you did, and you're going to make a huge change in somebody's life. So, thanks so much for your time.